There will be some data, I think, at the SMR meeting from Jen Wargo, where she talks about doing biopsies on patients who get brief periods of BRAF-MEK, and the rumor is that it's going to turn out that somewhere between 6 and 12 weeks is an optimal amount of time, because what happens when you, I mean, you folks know the data, I assume, better than I. What happens when you develop resistance to BRAF-MEK? Isn't the gene pattern somewhat like the resistance pattern to PD-1 therapy? Reinhard?
Yes, well, this is a very interesting topic. So what we can say that if you have a long time exposure to kinase inhibitors, there is a transcription adaptation, and this includes an upregulation, for example, of BRAF, but it also includes a change in the differentiation from a more melanocytic phenotype into a mesenchymal phenotype. And with this, the dependency of the tumor cells to the MEP kinase pathway is reduced, and therefore the treatment is less efficacious. And a similar mechanism can be seen in immunotherapy. Obviously, the mesenchymal stemness-like phenotype maybe presents less antigen, is less visible for immune cells. So there we see a common theme in resistance mechanisms, and also the keratinocytic phenotype of melanoma cells that was discussed yesterday is a phenotype that is associated with resistance for target therapy and maybe also for immunotherapy.
I think that's a very interesting concept, which has getting a lot of profile with the Cell papers. But I think one has to be a little bit careful. The patient number is very low. In fact, there's some overlap in the samples which were analyzed. And I mean, I think I found interesting yesterday the presentation by Tony Rebus on the patients treated with vemurafenib or the combination vemurafenib and cobimetinib, and the genetic analysis of complete responders and early progressive patients. And looking at the profiles of those, these resistance mechanisms you described, Reinhard, were not discriminating between.
But this was not acquired resistance. They compared, this was not acquired.
This was baseline resistance.
This was baseline resistance.
Primary
so actually,
resistance,
none of the patient had ever a response during the targeted therapy.
That's true.
So this is another population. And this shows us how complex the field is.
Yeah, so you're differentiating between primary resistance at the beginning of therapy, showing that it doesn't have a relationship in the BRAF-MEK population to immune resistance, but then the suggestion is when you acquire resistance after an initial response, then you might become resistant to immunotherapy. So is this the tumor striking back?
But the thing is, we are missing data. We don't want to be in this very difficult situation where we stop a targeted agent because patient is progressing, and then we are afraid when we stop, we interrupt the treatment, that the progression is going to be so fast that nothing is going to work afterwards. So that's why we would like maybe to initiate another treatment before that point. But we have no data of what would this very patient would do if we continue. Maybe we'll do well, and is it really smart to stop and to give something else? So we need to do that in a controlled way, in a smart way, with biomarkers.
I think such a trial needs, would you agree such a trial needs to be done perhaps by using digital droplet, either PCR or a single cell RNA assessment? Only with the single cell RNA assessment could you get this mesenchymal transition, which could be early warning that, you better stop the targeted therapy, time to switch to immunotherapy.
But you're absolutely right. This trial needs to be done, but 90% of the patients have no access to clinical trials. So, also the physicians who have no, center of excellence nearby and so on, they need to do something. And I have a good friend of mine in my age, she was suffering from stage 4 melanoma with multiple lymph nodes, axilla region, supraclavicular, head and neck. And she wanted to have a response as early as possible. So she was BRAF mutated, and she was on the BRAF plus MEK combo. And after 1 year, she got a 90% response, and we switched her to a PD-1 antibody, and now she is for 9 months in a complete response. So we have done this because also mechanistically we hope, at least we hope, that there was no resistance developed yet because there was no signs of resistance, and we can expose her. And this has been discussed here at ESMO and will be discussed here at ESMO again. We can expose her with a re-challenge to the same drugs again in spite of a progressive disease. And then we hope that we will have another response. But it's gut feeling, I know. But
I think this is a very controversial issue because, I mean, you have your patient is a perfect example of how beautifully BRAF-MEK is working. And I mean, we have now patients for years actually on drug. I mean, looking at the Combi-V and the Combi-D data, we are seeing that after 3 years, more than 25% of patients are still have maintained tumor control and are still on drug. Why should you have any benefit and taking any risk to a checkpoint blockade, which has a response rate of only 40%? Taking also a certain risk of relapse, and I have also experience with a patient actually who was not responsive after interrupting BRAF-MEK inhibition. So I think we need to test that in clinical trials.